So good evening, everybody, and welcome to another of the IOCP's webinars on the subject of lymphedema, current information and practices. Your host this evening is once again Martin Harvey, and the speaker is Jane Wigg, who is the director of the Lymphoedema Training Academy. Before I hand you over to Martin, I wish to advise you that this webinar is being recorded. And also, if you would like to ask any questions, then please do so by putting these in the chat box. We hope you enjoy this webinar this evening, and I'll now pass over to Martin. Thank you.
Thank you, Jill, and good evening, everybody, and welcome to yet another of our webinars. And we've got a particularly relevant one tonight. We're very fortunate to have as our speaker, Jane Wigg. Jane is a consultant clinical nurse specialist, and she is an expert, if I may use that word without embarrassing her, on the subject of lymphedema, which is something that those of us in podiatry and who do things to the feet do come across quite a bit. And I'm certainly looking forward tonight to the information that we're going to get from Jane's expertise. So Jane, as I said, is a consultant clinical nurse specialist, and she is also the director of the Lymphoedema Training Academy. So get ready for some training, folks, because this is going to be really, really good. So Jane, thank you very much for agreeing to talk to us tonight. And I think I can do little better than actually hand over to you to tell us all about lymphedema, please.
Okay, well, thank you very much, and thank you for the invite for this evening. It's a pleasure and a delight to be here. And yeah, I'm in need of you guys at the minute because I actually fractured my ankle on Sunday, so now I've got a cast on and hobbling around on crutches, so definitely need some support in that area as well. So okay, so I've been asked if I can just talk generally about lymphedema. I'm happy to take questions as they come in, but I'm going to give a general overview of lymphedema. And sorry, we just need to mute some people. Yeah, just a general overview of lymphedema, and then take any questions that you may want to ask me as we go through. So I'm just going to share my PowerPoint, and I don't want to create death by PowerPoint, so apologies if I do. Right, there we go. So let's just put that onto there. Oops, so I need to just switch the displays. Have you got the big picture there and not the little one?
We've got the little one and a bar at the bottom, which has got the run of it. Now I've got the bigger one.
Okay, that's great. So welcome. Yeah, I mean, probably you've seen some of these legs or legs similar to this in the past. And I started in lymphedema management back in '92, and I thought that we would have eradicated these types of legs and limbs over the years. Unfortunately, we haven't. We still see them, and it's a very common story and image that both you see and I see, I guess. And with lots of the education that we've done, I know the area that I've been practicing, which is Wolverhampton, Stafford area, we see less of the severe, but of course lymphodemas are starting to get more evident and prominent because as a country we are getting older, we're living longer, we have a higher life expectancy, we're managing to survive longer with cancer, which has the consequential side effects. We are becoming obese, meaning that we have a knock-on effect from that as well, and we're becoming less mobile with heart, other comorbidities. And so that means we have a consequence for lymphedema all the way through. And so I just wanted to go through some of that and see what's new. And I'm sorry if I'm repeating some of the things that you know. So this is a slide that I use a lot, which is a mind that's stretched by new experiences can never go back to its old dimensions. And for me, very much, it's about what do we know, what's moving, what's changing. And it's taken a long time for lymphedema to step forward, but we've certainly got a lot of changes taking place over the last few years. And particularly since I've started working with lymphofluoroscopy, which is an imaging technique. So as you've said, it's Lymph Vision and Lymphoedema Training Academy. We are an international training academy with Lymph India, Lymph Africa and in the Netherlands. And just to blow my own trumpet, because I'm not very good at it, but when we started to work with fluoroscopy, we were told it was quite dangerous, it might be harmful to people, and it took a lot of changing and opening people's eyes to what we were doing in order to see that. And so we have won several awards now, the last one just being the World Union of Wound Healing and Compression Award for compression MLD. So very happy that it's been acknowledged that the use of fluoroscopy in what we're doing is actually very worthwhile. So we've got a great training team, people across the UK and the rest of the world. And I'm not going to dwell on any of these, but, you know, we know that it's all about teamwork. It's not just about me, but my name kind of gets banded with it, but it's everybody else that's contributing to what we're doing. And what do we do with Lymph Vision? Well, one of the things that we're doing is we are injecting something called indocyanine green, which is a protein that gets attached to the natural lymph within the circulatory system. We inject that intradermally, and that allows for us to see images of the lymphatic system. And then from that, we visualize it on a screen, we record those images, and it tells us where the lymphatics are functioning, where they're blocked, sometimes what type of genetic abnormality that the patient has, so that we can improve their treatment. And it really does make a difference to the outcomes of treatment. So just to show you a quick video of this, this is fluoroscopy. It's 0.01 mil of indocyanine green, which is very, very small, and that's natural progression, that's real time. So there is a thought that the lymphatics are very, very slow, but actually they're not. When they're being filled, they are functioning and working, if they can function and work. And when they're not, they're sitting around, inactivity, no movement, and the lymphatics are not taking in any lymph. And you can see that that's just there going to the lymphangion, which is the little valves between a collector, is just pulsating and pushing that fluid along. What will happen in a minute once I've injected this second side is that we'll turn the lights off and you'll get some better images, because we have to work in the dark. So I never thought my occupation was going to be working in the dark most of the day, but there we go. But it has given us light and allowed us to see great things. So moving lymphatics there, and you'll see that just across the shin in a minute as it works up. So I'll just move that forward, and you can see normal. So we can see normal anatomy, and we can see abnormal anatomy as well when we're working. We'll see some of those later on. So it will tell us what's going wrong with the lymphatic system with the images that we do, and that's what the private clinic is that I do. But what is lymphedema? I mean, surely you've seen legs like this in the past, I think, and unfortunately it still happens, and you'd hope in my lifetime that we'd be at a place where we'd be able to prevent and educate and get improvements of this. Goes without saying that somebody in the right footwear and within the right shoes and with some mobilization and activity might be able to get those legs to improve. I just need to move the bar over again. And lymphedema comes in many different forms and types. And we know that it is chronic edema is anything that's been there for longer than 3 months. But as I just said about my fractured ankle, if I've got swelling before 3 months, I should really be reducing it and get rid of it before then. And that's what I would expect to do. In fact, I've worked really well on it and have very little swelling at the moment. And so we know that we can reduce and improve a lymphedema much quicker, and what we should be doing really is stopping it getting to a chronic phase by early intervention, early implementation of treatment. Unfortunately, what we have in some of our practices and guidelines is that you wait until it's bad enough, and then when it's bad enough you can implement treatment. That's similar to a lot of other treatments, but I'll always say when I'm teaching, well, we wouldn't wait for a diabetic patient to be in a coma before we treated them. Why are we waiting for such chronic conditions in these patients before we're starting to give them the treatment that they need? So 3 months is the official kind of guideline of a chronic edema, but we know it's intermittent before then, and that with some input we can reduce and improve those swellings. And what happens? Well, we get a little bit of don't all people have a bit of swelling? Or I've always had swelling, or they can't wear the garments anyway, so it doesn't matter how are they going to get them on? People saying, well, my mom had chunky legs, so it's my legacy to have those chunky legs. And of course, I don't have the skills in order to treat the patient, or that the patient is non-concordant. I have a big lecture about non-concordance and what drives to people being non-concordant. And quite often it's just lack of understanding, lack of time, other things going on in their life that is more priority at that point, rather than looking at the lymphedema as well and putting time into their own condition. So there's common myths I'm sure you've heard of, saying that I saved your life. What more do you want from those cancer patients? Or give it a rub. The number of times I've heard that. Sit on it as well. Sit on your hand, which is actually something we do talk about now because we've found new drainage pathways. Water tablets, which we know don't work with lymphedema patients. We'll deal with it when it gets worse, which is then quite often too far gone. Children don't get lymphedema, or it's not lymphedema. Now, one of the things that we know is that all swelling is a lymphedema. But as I said, when I started off, we've got so many different things now that are adding to patients that have swelling, and we can add COVID into that as well because of all of the side effects of that. So lymphedema, it's not a new problem. It's been around since man began, but it's been given some glamorous terms maybe over the years of just a lymphedema. Elephantiasis is a classic term of that, for that chronic swelling that people have. So what is it? It's a swelling. It's an incurable condition. Vaughan Keeley says there, who does work in Derby Hospital, as a result of an accumulation of fluid, fibrosis and fat in the tissues as a result of lymphatic drainage. Now, one of the things that's changed over the last 10 years is that the theory of fluid exchange. And what we know from fluid exchange is that all fluid that is pumped into the skin is removed by the lymphatic system. So anything that happens is that we have to keep the lymphatic system functioning, healthy and working in order to drain fluid. So the lymphatics are incredible all over the body and drain all of that fluid away from the skin. But we have to remember that the lymphatics fight infection as well. And so when I started lymphedema management back in 92, I was told, well, you don't need to worry about that the lymphatics fight infection. You only need to worry about the fact of where the fluid is draining to. And now we understand that that is so wrong, because there's so much inflammation around there talking about the increase in inflammatory cells and markers and so on, which is the beginning of a lymphatic failure. So the connection between the lymphatics and the veins is that your heart pumps and you push the blood around your body, and that the fluid is drained away by the lymphatics. What we thought historically, and this still gets told today, is that 90% of the fluid is taken back into the venous system, and that's incorrect. It's all taken away by the lymphatics. So you've got these lymph nodes around your body fighting infection and draining fluid. And if you just have a look at this little video here, let me just get rid of that again. What you'll see here is the normal running of the lymphatic system. So you've got little valves between the lymph called lymphangions. This is normal, the peristaltic action of the lymphatics. So the fluid is filling from the right hand side going to the left. And as soon as there's enough fluid in that, it triggers another sensation. It's called a KL cell, and it will push the fluid along 3 or 4 lymphangions at a time. If that mechanism doesn't happen, someone doesn't have the KL cell, or the lymphatics aren't being filled, then fluid can't be pulsated and pushed along the lymphatics. And so it will stay in the skin. And the longer it stays in the skin, then the more fluid you get. Now, the problem with this is that if people are not moving, and you probably see many people who aren't very active, there is no fluid going back into the lymphatic system and draining away. And so one of the key things that you'll keep hearing me harp on about is activity and movement. It's absolutely essential for fluid drainage of the lymphatics. So this is what the lymphatics look like. The fluid is sitting in the skin. It goes under into this area from the initial lymphatics, get pushed through, and then it builds up and gets bigger and bigger and bigger and bigger until it contracts about 300 times its capacity. It forces the fluid along, and as long as you've got good valves there, it will keep pushing the fluid along. But sometimes if the lymphatics are really engorged, the valves can't work and the fluid stays in the skin, a little bit like your varicose veins that you see, or exactly like your varicose veins that you see. And without going into too much detail, you've got fluid that enters from those collecting vessels and will go into a lymph node. And it's only here that fluid will get taken back into the venous system. And they reckon that's about 40% of fluid, but we don't really know because that's kind of old news, really. So it may be a different quantity than that now that we can magnify better. So that's in a nutshell how the lymphatic system runs. And this is what those initial lymphatics look like under the skin. And the reason I go to such a microscopic level is because we all think about the bigger vessels and not the beginning. And what we need to do is to think about where the fluid starts from, these very, very small vessels, and where it gets taken to. So these are the very beginning of the lymphatic system, the filaments of leak. And as you get inflammation in the tissue, these tissues will start to not be able to stretch and they become congested and blocked and not able to open and close properly. And the caliber of the lymphatics becomes smaller, meaning that their capacity of fluid they take is less. So they can't take the same amount of fluid. So really, we need to get down to that fine level of thinking about stopping inflammation to start off with, which is very difficult as well as a healing action, and then thinking about how we're starting to drain fluid. And this is why we need to start treatment as early as we can. And then you connect that to the venous system. And the venous system, of course, it's circulating, that microcirculation, pushing the fluid out, but not all the fluid leaks out. So that stays in the vessels, it goes back to the heart, transfers back to the heart. But within the venous system, you have something called the glycokylax layer. And this is like the Teflon layer on a frying pan. And if you scratch the Teflon layer on your frying pan, things tend to stick. So things tend to stick like atherosclerosis and red blood cells. And because the Teflon layer, the glycokylax layer is reduced, it means it's more porous. So it allows for more fluid to leak out. And the only way in which it can stay healthy is by movement. So every time someone moves and blood gushes across this, it keeps the glycokylax layer healthy. And if they're not moving, they're not active, it breaks down and fluid leaks out. And that's why we get a high filtration edema, putting more pressure on the lymphatics, meaning that lymphatics swell. So we've got lots of people that fit into that. Residential care, that lady that you saw at the beginning in her purple slippers is a residential care lady. People that are immobile, have had road traffic accidents, sporting injuries, cancer patients, and any other chronic illness as well can lead to immobility, leading to a more leaky blood vessels, putting more pressure on the lymphatics. So you saw these before, but if I just show you the one which is the lymphatics and how that looks, you can see when we're injecting into the lymphatic system of a congested patient, and you'll have seen this fluid on the top of people's feet many, many times. You can see that's going nowhere. It can't find itself into the lymphatics that are below because they're all so have so much fluid sitting around them, they can't open and close in a response to movement, and then the fluid is just sitting there. Of course, what we're watching is the movement of ICG, not actually the movement of fluid, but it's one and the same thing in reality. So the ICG allows us for us to see different things that go on. It allows for us to see things like you might put your patient in a stocking. So here the patient's gone in a stocking, but you might see swelling around the top of the knee when they're in a below knee stocking, meaning that you need to take the stocking really much higher. Of course, concordance and what a patient can tolerate can be really different. But in reality, if we don't have the support to the lymphatic system, it will just start to swell further and further up. Exactly like you've seen it when somebody puts a bandage on and the toes start to swell. It's because you don't have that support from the toe all the way up, even if you've got it on the top of the foot. And we now know that when we have a very early lymphedema and we compress this very superficial network, which we'll say is the third drainage system, is the skin where the lymphatics reside, if we put compression on, it squashes that drainage system and it actually makes it worse. So we're learning lots and lots about how we can be treating or treating better with what we see. One of the tools that we use is this. It's called a lymph scanner. And a lymph scanner measures the amount of fluid underneath the skin, a little bit like bioimpedance, if you've come across that. And we can see here, for example, what we've measured is 56, 57 on the monitor there. And where there's no edema, it's 45, which is normal skin, what we'd expect with fluid in. And where there is edema, it's 56. So it's an easy way, but expensive, because they're about £4,000, for us to monitor where fluid is situated. So there's many different reasons for edema, but it's all about whether your water that you're pushing out of your tap and the plug hole that you've got is able to function appropriately together. So you have a normal amount of fluid going out, a normal amount of lymphatics draining, you don't get a problem. But if you have too much filtration, too much fluid going in because the glycokylax layer has broken down, or maybe in response to an injury you may have seen, then you'll get a flooding of fluid sitting into the tissue, and then the lymphatics might be normal, but it's a very watery edema. So you'll know that those tissues will pit when you put your thumb on them. And then you can get your lymphedema, which has got very much more proteins, and it's much more concentrated, and it's due to the lymphatics, which take the large macromolecules away. But the filtration, the venous side, is fine. In many patients we see that are older, it's a combination of both that's the problem. So, but all edema is a lymphedema. So there's a trend to stop calling a dependency edema, a venous edema, being those terms, and understanding it is a chronic edema if it's there for longer than 3 months, 12 weeks, or it's a lymphedema if we're talking about it being there with a failure of the lymphatic system. But they are one and the same thing, which means that the terminology is slowly changing. And you can get other things as well. So you can get, of course, patients who are born with a swelling as a primary lymphedema. They may be born with it, or it may be that there's a genetic abnormality and it will come later on in life. Hereditary, genetic, or a syndrome, a combination of many other different causes. And we've got 23 genes that have been found now. When I came into lymphedema, we knew about Milroy's disease, which may be something that you've heard of, because we know Milroy's disease is a bilateral below knee swelling. And it won't be Milroy's if it's not bilateral below knee. That's what the genetics have led us to now be able to understand. So there's different classifications. I'm not going to go through them, but as an example, this patient referred to me back in the 2000s. I was told she was a Milroy's disease, but what we've learnt over the time with the work of Peter Mortimer, Christiana Gordon, is that she could never be a Milroy's disease because she's only one leg, a unilateral edema, and that's not what that is. So there's many things now which are changing our ideas of lymphedema and how we treat them differently, because of the different type of genetic mutations and causes. And we can see there again that young man and some of the lymphodemas which have a genital swelling, a problem with the lungs, with the heart, with the kidneys and so on. And so as well as just the lymphatic system. So it's all associated. And then you can get all of your secondary lymphodemas, which is a cause due to an external factor, not something that's inherited or that you're born with. And I'm sure that you know these, but it can occur due to surgery is probably one of the most common ones, usually cancer surgery and usually through having your lymph nodes removed. Radiotherapy, injury, infection and trauma. And we've had people that have been, for example, a lorry driver who's sitting a lot because he's sitting and his feet are down and his scrotum squashed. Sometimes you'll develop a scrotal edema as well as a lower limb edema as well, or people that have had a sports injury and they'll have a long-term lymphedema following that as well. So lots of different causes. Tumor, venous disease, so your lymphovenous, your varicose veins, your leg ulcer management. immobility, from anything from having an accident to MS or a CVE, a stroke or something. And then we get parasitic infection, which isn't very common in the UK, but we do have Lymph India and Lymph Africa, and so we do see lymphatic filariasis there. And obesity related. One thing that we say about that from an anatomical perspective, or physiological as well, is that you're born with one lymphatic system. So let's say you're born with a lymphatic system that would serve a body usually of 10 stone in weight. Let's say it's 10 meters of lymphatics, but you start to become 20 stone. I'm using stone, sorry, stone in weight. You don't have 20 meters of lymphatics to accommodate that. You have the same. And although you do grow some of those cells, they don't function the same and they won't work. And so that's why many obese people do develop a lymphedema. But many obese people don't develop a lymphedema. And so there is a lack of understanding of why that starts in some people with obesity and not other people. And there's factitious and artificial edema. So we could relate this to people who are obese, people who are not helping their own lymphedema, but generally we'd put it down to someone who's maybe having a tourniquet around their leg because they don't want to work or something. But I also, and openly say this, we see a factitious edema in toes where somebody's been bandaged wrong, or around the knees where someone's pushed the fluid to and not addressed that as well. So they fit into that category. We do know that secondary lymphodemas are lessening, and that's really good. It's to do with the lack of, or the changes in radiotherapy and surgery, but more patients are being diagnosed and people are living longer, meaning that they've got more chance to develop a lymphedema along their cancer journey also. So breast cancer patients, it's 5 to 25%. However, because some people have sentinel lymph node biopsy, which is they take the first node out that the cancer is going to, it has reduced the incidence of the lymphedema in those groups of patients. We're well behind with that when we look at our gynae patients. And our work has demonstrated that 61% of gynae cancer patients have a genital edema. That's what we've picked up with fluoroscopy and imaging. And of course, it doesn't commonly get discussed or talked about. And venous insufficiency, you may have seen patients like this, I'm sure. But what we have to ask ourselves here is that this is a 25-year-old man. So why does a 25-year-old young man have such an advanced venous problem? So we can see the varicose veins there. So we have to stop and question those things when we're assessing patients. He is obese, but you see many 25-year-old people who are obese that don't have the same vascular problem. So it may well be that we need to look at genetics and hereditary things with this gentleman as well, to try and understand better what's happening. A post-traumatic. So this is a young lady that had an accident with a bus, and she had skin grafting after. And you can see the edema around the ankle. But what the good news with that is that although the edema is on the ankle and some of it through the graft, above the graft, the lymphatics are draining normally. So the job is only to get the fluid to where the lymphatics can function better. And then we can start to improve her lymphedema for her. And then there's many other factors that will affect people that have got a lymphedema. So going back to mobility, immobility, as we all get older, like other blood systems, like the other blood system, not other blood systems, we develop thinning, atherosclerosis, sclerosis of the vessels, and we have that of the lymphatics as well. And then something else you may come across, but lipedema. It is gaining a little bit more airtime now, and lipedema is the abnormal laying down of fat in areas of the hips, the buttocks, the thighs, and the calves, not on the tops of the feet. So you'll have somebody with leg swelling, but not foot swelling. And it may be different sections as well, because it's not only present throughout the whole of the limbs. It can just be above knee. It can just be below knee. It can be just around the hips and the buttocks. So lipedema mainly affecting women. It's not cellulite. It does quite often get misdiagnosed. And this picture here of the two ladies, they're sisters, And you can see really that the waist is about the same size, but you can see that the proportion of the legs is quite different. And with lipedema, you tend to have a cuff at the ankle and where the fat is laid down. So there's a lot of work taking place looking at lipedema. We think it's about 11% of the female population have lipedema, and they don't usually know. Their legs start to get worse at late teenagers, and then they might start to question why it is that through having children, pregnancy and so on, that hormonal changes, that the legs start to tend to get worse. And there's nothing you can do diet wise, it's not related to that. And that the legs are very tender, they ache, have varicose veins quite often, sometimes hidden by the fat layer. And it's a very common problem and very often misdiagnosed or not seen. It does develop into a lipolymphedema with time because the lymphatics start to fail by the obstruction of the fat cells around them, not allowing for the lymphatics to work and function as well. So, well, it can affect anyone, really, lymphedema can. And we do see many, many people from different backgrounds, different occupations, different activity levels, families, and so on, that lymphedema affects. And treatment is quite challenging because it has to be about self-management. And it's a lifelong condition, so we expect and want patients to maintain their condition themselves with our support lifelong. So patients may go into what we call maintenance therapy. And I think that's a difficult term as well, because nobody ever came to me to be maintained. Everybody came to be reduced, but we call it maintenance therapy. And that's what is probably classified as your simple treatment. And it's where I think that as an organisation and a group of professionals, you can really assist, where we've got people who have a below knee swelling, ankle swelling, not as active. And you can do things like well, you can tell me whether you can, but skincare, exercise programs, compression garments, activity, in order to maintain and improve that situation for them. And then what we might need to do with patients is we might need to do intensive treatment. So they'd come in on a daily basis, having a combination of bandaging, of skincare, of exercise, of manual lymphatic drainage, or compression pumps maybe. We'll see some pictures of those in a minute, in order to reduce the edema quickly, and then to keep it there and then get the patient back into a maintenance program. And then we have palliative therapy, of course, for patients who we want to maintain comfort for the patients, but maybe we lose control of the lymphedema as the disease progresses. So there are many different treatments options. You might be using some of these already. We use a lot of skincare. We don't see many wounds, I would say, in classic lymphedema management. You only see it in your combined care, so your leg ulcer management, but generally a classic lymphedema of your arm, for example, or your legs from a gynae or a different type of cancer, they tend to not have any skin problems, with the exception of lymphorrhea, that leakage of fluid out. Exercise is so important, multi-layer or multi-component bandaging in order for us to encourage the fluid out. Weight management, lifestyle, weight control is essential. Lymphatic drainage, where we can encourage the fluid back into the lymphatic system where it is draining normally for it to go on its journey. We use pneumatic compression pumps, and the pumps will encourage fluid again in the same direction back into the lymphatic system and then back into the venous system when it hits the nodes. Psychosocial support is essential. It is a lifelong condition. They are going to have it for the rest of their life and need to manage it the best that they can with our support. There is surgery is available. They do something that is called lymph-venous anastomosis, where they will take a lymphatic collecting vessel and they'll put it into a vein, so it will bypass the rest of the lymphatic system. And sometimes they transplant lymph nodes, and sometimes they do liposuction, where when the fluid has been there a while and it's changed to more fat rather than fluid, they'll be able to suck that out, and then the patients will have to wear compression, usually lifelong following that. Kinesiotaping, you might be using that as well. So kinesiotape allows for us to direct fluid elsewhere and increase the capacity of the skin to drain fluid. And low-level light therapy or photobiomodulation as well is a great favourite of mine for wound healing and for changing lymphatic fluid. And it's the only thing that we use that changes at a cellular level rather than treating a symptom with changing the cause. So essential care, and the other key thing with that is self-management. It's all about supporting the patient to do the best that they can with their skills. And if we can upskill patients and get them as close to doing what we can do, then we're going to be the most successful that they can be in maintaining their condition. So some of these treatments you may have seen, we've got laser or photobiomodulation on the top. Well, we use it for teeth, for oral lymphedema as well. We use it onto breast edema, and we'll use it for healing things like toes, which are difficult to heal. You've got pump therapy. You'll see one working on a video in a minute. Negative suction for reducing fibrosis. So historically, we would have used our thumbs to reduce fibrosis or our hands, but now we've got machines that can assist as well. General support, advice, psychosocial, compression bandaging, using manual lymphatic drainage, and some of that is pretty easy to do without any main skills. So we can implement some things such as emptying the lymph nodes and getting your patient to empty the lymph nodes just by putting a ball underneath the knee and squashing it. Means that then those nodes are empty and the fluid that's blocked below can start to move up. And kinesiotaping. So some simple quick wins. But compression therapy is the mainstay of what we do. It reduces the edema by pushing the fluid to the root of the limb. It stops it coming back by not allowing for the elasticity of the garment to stretch. It encourages the muscle pump to push the fluid up and out. And yeah, generally the key thing with it is it has to be comfortable. And what happens quite often is that patients are put into the wrong garments, they're not comfortable, and then they become non-concordant or reluctant to try the compression. For me, flat knit garments win 99% of the time because they're the most comfortable for patients. The other thing that we need to think about is lots of the garments that patients have from a lymphatic perspective are designed on a venous perspective, where you don't need much high pressure at the top of the leg. Whereas in a lymphatic failure, we have edema throughout the whole of the skin and we need a very high compression as we get to the top. So if this was 100% of the compression, we'd still want to be having 70 or 60% of the compression as we get to the thigh, because the fluid is still in the skin there. So choosing the right garment, selecting it appropriately is key to improving those outcomes. And compression bandaging as well works really well. You can be very specific with where it is. And I think that a lot of compression bandaging for venous particularly is focused below knee, but with an edema, you may have seen patients in bandages, it is being forced up around the knee, and we need to train you how to bandage the whole of the leg above knee in order to assist with improved outcomes and drainage. And yeah, it's good fun doing bandaging training. It's one of my favorite things to do. And we'll train on lots of padding and so on, so that we can get some different shapes for the students to be practicing and training with. And of course, it's upper limbs as well, not just lower limbs. One of the things, or some of the things that are available here, just thinking about it, is the red leg pathway. And there's a big difference, not a big difference, but there's a difference between people being given antibiotics for red legs, which we think is cellulitis, but it ends up being inflammation. There's also the Doppler. So there's the use of compression that the British Lymphology Society do as well. And so that will take you through how you can apply compression garments without the patient having had a Doppler. Lymphoria, so that leaky leg, wet leg pathway, got a link to that on there as well, Lymphoedema Network Wales, and cellulitis guidelines as well from the BLS, and your antibiotic program and regime from that. So some of the things that might be able to assist you moving forward with that. And about us, well, we're world leaders in fluoroscopy guided manual lymphatic drainage. And that's important because back in the day, so going back to this in 2006, we were told that MLD on its own is not sufficient to treat lymphedema. And MLD is manual lymphatic drainage. So it's a kind of a massage technique for moving the fluid to an area it can drain. And what we've done with fluoroscopy, it's allowed for us to see common pathways of where people are draining to. So this lady, for example, her hand is draining well. She's collected fluid in the middle of the arm, and then she's got a pathway draining up over her shoulder and draining up to the neck. So if we know that that's where she's draining and how she's draining, it's easy for us to teach her to push the fluid that way and then for her to empty her neck nodes. So it really is altering and improving the drainage pathways you can see here. And lucky for her, she's got what we call the tricipital pathway. So it goes around the back of the arm. It's called the Kaplan pathway as well. And you can see a fluorescent node there. So she can push the fluid to the back of her arm or get someone to assist her with that. And by knowing that we can empty those nodes, she can get improved outcomes. And those nodes naturally empty when you're moving. So again, exercise is good. But if somebody is not exercising as much because they're worried about the weight of their arm or from their surgery, then maybe they're not draining as well. And the same here. So by looking at the drainage pathways versus the anatomy allows for us to be able to see where blockages are, where we can drain fluid to, and how we can improve those outcomes for patients. So that's an anatomical autopsy of a fetus there that you can see the drainage pathways on, and the work from Hiru Shirami, who's remapped as well the lymphatics using lymphofluoroscopy. And I've adapted that to take that up to the iliac nodes from what we've learned. And reconstruction, so people are having are coming to us to see how we can inform the surgeon of which lymphatics are draining and where to avoid when the person is going to have more surgery. And the same when we've got patients with gynae patients here. So she's had lymphedema in one leg. She already has a pre-existing venous problem. She's got the edema situated on the medial aspect of the thigh, but below knee, her lymphatics are draining okay. And we can see that she is full. So this black line here is demonstrating that she is full all the way up, including the genitalia. And so we need to be addressing and assisting these patients with this. So just pushing that fluid up from your below knee bandage can be creating some problems above that sometimes we don't ask the patients about what's happening to them. And what it's also led us to believe is, well, are we putting patients in tights and that's constricting? Because we're seeing this time and time again when we're doing fluoroscopy. When we use we, I mean me. When we're seeing lots of patients with this. So lots of things for us to be changing. So early identification is the key for us improving care for lymphedema patients, starting early, mapping them and screening prior to having their breast cancer surgery or their gynecological or cancer surgery. And then we can inform the surgeons of where the lymphatics are draining to. So for example, this is the sentinel node. We inject it, or we inject the tumor, and we can see, we inject the tumor site and we can see it's draining to this node. So if that node's removed, but these are left in place, that means this arm can continue to drain pretty well. So lots of things taking place, and we can remap them after through screening to make sure that that patient doesn't get any changes. And if she does, then we can address those early and intervene with treatment and self-management. What we've learned is that if we can move our fingers correctly, then we can move the fluid. And you can see the lymph in the whole of the hand there, and I can push that up and have the fluid above my fingers. And I am speeding things up a little bit because I know I'm talking a lot. And then we can fill the lymph again. And unfortunately, we found that we can fill faster with our thumbs and with our hands than we can by a patient exercising. But of course, exercising is better than us being on somebody's foot or a hand all day. So exercise is good again. And yeah, just this patient, this one here, we can be just looking at where the blockage is from the wrist. So the hand is okay there. And as we work through, we can see all of the fluorescence of where it's blocked on this patient and where she's draining normally. It's giving us a lot of ideas of what things are changing. So I said that one of the other treatments that I love is photobiomodulation or laser light therapy, great for healing. And we use these little handheld lasers and some of the big ones. They actually have a great one that's called a Novothaw, which is like an old sunbed that you go in, and it makes your cells be healthy and happy and able to work better. So, and pumps you may have seen, I'll just put this video on for you. So you've probably seen the old Flowtron pumps. They're much more advanced now, and that because of what we've learned from fluoroscopy, we've modernized pumps, the sequences. The LymphFlow Advanced is based on the fill and flush method, and it will allow for focusing on a different part of the arm. It's got many sequences on it, of the arm or the leg, and will push the fluid out, similar to manual lymphatic drainage. And then just to say exercise is important. Emptying your lymph nodes. You may already be doing this with patients, but pumping on the ball, there is a deep drainage system from the sole of the foot to the popliteal node. So if your patient can pump on a ball and then they can empty the nodes behind the knee, we can get some improved drainage for them. So in summary, lots of different things are available for lymphedema management. There are lots and lots of things that are coming on board. Wraps, you've probably seen wraps that people have now, negative suction, lymph yoga, vibration plates, many, many different things. Genetics are coming on board. They're using different things in surgery, which makes the surgery much more successful. So we'll see that coming with time. Yeah, health and wellness is so important. Anti-inflammatory diets and medication, and genetic medication. So yeah, it says there, we've got smart pumps, smart diet, smart fabric, smart clinics, lots of different things all coming on. And then just to demonstrate pre and post treatment, really, we can really get some great results. This patient had 2 weeks bandaging, and then she had pump therapy at home, and that's the outcome of that. So just to say thank you very much for your time, and I think we're at the end. So I do go on and just say about the training that we do, but yeah, let's leave it there for a very quick rundown of lymphedema management.
Jane, I'm absolutely entranced. I am absolutely fascinated by that. There's so much of that I can relate to in my day-to-day practices. You know, where we see perhaps what we don't fully recognize as lymphedema when we actually, you know, when we actually encounter it, and we encounter these people with springs in their legs and their ankles and so on and so forth, with saturated bandages on that they've had on for sometimes years. You know, they're suffering with that. I confess, I did not know that there was this amount of work done around the lymphedema.
Okay.
Certainly when I was doing my training, you know, they mentioned the lymphatic system, and it was probably about an hour, something like that. Well, there's the lymph system, you know, right? Okay, there's the lymph system. Now let's get on to the vascular system.
Yeah.
And I suppose it's probably pretty similar now, isn't it?
Yeah, and as a nurse back in '86, I trained. I think I did the same. We had 1 page or 2 pages in a book. It was the Let's Nursing book, I think, and that was it, the lymphatics, and it was about immunity and just nothing about the lymphatic system, really. So yeah, it's very interesting, lots of changes and lots of work happening.
Well, indeed, and of course in podiatry and you know, other foot health activities, we so often encounter it, but I'll be frank, when I encounter it, I don't know what to do about it. You know, I'll tell people, yes, lose a bit of weight. I'll tell people, right, you know, move around a bit, but that's as far as it goes.
Yeah.
So how do we get more information? How do we perhaps incorporate some of the simpler elements into our practice? How do we get in this?
So just as a quick overview, we do train, we do have lymphedema management for lymphedema, lower limb lymphedema management, sorry, we call it TAP, which I thought was great, treatment advisory program, because we'd all like a tap on your ankle. I think that would be the easiest thing to do. where we go through basically what I just told you in 45 minutes, but in 3 days, and give you some practical skills as well. And then that goes on to a part 2 course where you'll have more competencies and things like teaching you as an advanced lymphedema. I'm not going to say it's advanced, but to be able to bandage above knee as well, and recognizing that and where that fits into people's roles, because it will have to become an advanced role. But prior to that, doing good bandaging below knee, understanding compression better, understanding the advice and the support that you can give to your patients. So that is available. And I forgot what else you've asked me. Sorry, Martin.
Well, no, basically you've answered it essentially, because I said, what kind of training is available in this? Because
yeah,
we need this in podiatry. We do need this. It's something that fits in so well with podiatry. The number of people that we see with lymphedema in their lower limb.
And one of our trainers, Aaron Knowles, he's a podiatrist by background. He works at an organisation called Heal Logics, which is in Eastbourne, and he's assisted us with this training, and he's a advanced practitioner now of wounds and lymphology, working as or originating as a podiatrist. So it fits in so well and complements each other. And we all bring so many different skills as well. Yes, I know about lymphedema, but I don't know about all of the other things that you do. And vice versa, if we have a dermatologist that works in a team, or a physiotherapist. So everybody works together so well as a lymphedema team. It's so essential.
That's one of the areas actually that podiatry falls down in, is the multidisciplinary team approach, because a lot of podiatrists, way more than 50% of podiatry is actually practiced in private practice. So they don't have the support networks of working in the NHS, working in hospitals and so on and so forth. So as a single practitioner, sometimes they're just paddling their own canoe, so to speak, without knowing what kind of support exists, and without the benefit of working in a multidisciplinary team. So I think it's really relevant to podiatry. This is where are these courses held, Jane?
So we're based in Staffordshire. So it's the old Stafford University. So we're in Stafford. It's junction 1314 of the M6. And abroad as well. So not only the UK, but the UK is probably what's relevant tonight. If we do have a big group as well, so if there is somewhere, your venues, for example, or something, we will go to a venue. But if it's one-off people, then they can come join us in our other classroom as well. So we will go to an organisation and train there.
So the funding for these courses like this, so people fund these courses themselves, do they, or do organisations?
Yes, I would say it's mixed. We have mainly NHS students that come on, so nurses, physios, occupational therapists, but we have many private chiropodists, chiropractors, podiatrists, radiographers also come on, and some are NHS and some are private funded.
Okay, have we got any questions from the floor, Kirsty? Or is everybody still pretty much like I am, absolutely entranced by all this information?
I can see 20 questions.
Right.
No, but yeah, the ones I've got, if I'm looking at the same one as you, Kirsty, are just general comments, I think.
Same as you, Jane. Well, thank you very much, and very informative. I've just asked anybody if you do have any questions, but we've got 5 more minutes, so please, no such thing as a stupid question. Put them to Martin, put them to Jane.
Yeah, because I think sometimes when I come on and I go blah, 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 everybody's like, whoa, and absolutely no stupid question. And, it would be the same the other way around. If I was listening to you talking about something, I'd be, whoa, I didn't know that and that and that. So absolutely, yeah.
One of the things I was wondering about, Jane, was I'm often asked about these circulation boosters that they promote on TV, these gadgets that they put their feet on and then puts current through them, and it contracts and expands the muscles. do they do any good for lymphatics?
When they first came out many, many years ago, I have a story of a patient who had a dependent edema and she bought a circulation booster. And she came in the one day and we said, "What's happened, Mabel?" And she said, "I bought a circulation booster," and her legs had suddenly gone down. And we don't know whether that's coincidence or not. There's no evidence from a lymphatic perspective that we know. But if you do look at vibration plates, one thing that we know about vibration plates is that they are supposed to assist circulation, and they started to use them for the European Space Agency when people were coming down from the Space Agency in order to repair the glycochylax layer. So I don't know how much evidence is within that. If it does do something, then I think, yeah, that's great. What we would like to do is to inject somebody with ICG, and we'd like to see whether them just sitting there with a circulation booster actually moves the lymph. And I think that would be finite for us. So if anybody has one, wants to loan me one and wants to come along, we can do that if somebody comes with edema as well, and we can have a look.
Now that is a very good, that's a very good idea, actually. I saw a question come through there. Right, well, there's actually several. So the first one is, if a patient is not mobile, would a sit-down cycle machine be of any help? And that's Christina.
Yeah, I think so, absolutely. I think any activity helps. So even the flexion of moving your toes, we've seen that with ICG movement as well. If you just move your toes, we can see lymph move because you're moving the muscles and the ankle partly, but just the muscles within that and the tendons. And so absolutely, exercising on a small cycle will definitely make a difference. It's about keeping the glycochylax layer healthy and stopping it breaking down. And what we do know is that the way to do that is not to be like this, but to lift your leg up and let the blood come down, and then put your leg down, then lift your leg up and the blood will come down. But of course, not everyone's able to do that, but 100%. Any activity is good.
Right. Now, there's another one from, sorry, I think it was from, I don't know whether it was from Christine or Janet, so I apologize, or Lisa. But the question is, does deep oscillation help? Now, I'm not quite sure what is meant by deep, well, I know what oscillation is, but what deep oscillation is it a specific type of therapy, massage or something?
Yeah, deep oscillation therapy is a tool that causes vibration, the same. And what you usually do is you take an electronic current and it will vibrate your hand as you're massaging a patient. So there is good evidence for deep oscillation therapy, yes. Whether it's more useful than some of the other therapies, I don't know. So it's used usually in addition to other treatments such as manual lymphatic drainage and also compression and exercise and so on. So there is good evidence for deep oscillation therapy, yeah.
Right, and another one, and this is from Lisa, I think. Can I ask about wraps and support stockings, please? I've seen a huge difference with the wraps with a couple of my clients, and I wondered why they have wraps now instead of stockings.
Yeah, wraps are fantastic, actually. And when we do bandaging training, we'll often get asked, why have you taught us to bandage when we can put a wrap on? So with a bandage, we can be a bit more specific where we want the compression to be. We can use foams to divert the fluid from one area to another. And so what does it say specifically? It's seen a huge difference with wraps, and a couple of my clients wondered why they have wraps now instead of I think the one thing that you can do with a wrap is you can be much more specific. They are less forgiving. You can pad under a wrap if you've got any skin folds, and so you can get even compression. Sometimes compression garments, depending if you use an elastic one or a flat knit one, might push into the fold because compression's greatest over the smallest circumference. So if you've got a larger foot and then a smaller ankle and then a larger calf, it's going to collect around the ankle. But if you use a wrap, you can pad around the ankle and you can get a good even compression. They're also cost effective because if the limb volume goes down, you might need a smaller stocking, but with a wrap, generally you can accommodate a larger size limb, and it will continue to reduce as you go through. So I think wraps have really made a massive difference to treatment. There are different types of wraps though, and some are more comfortable, they get tolerated better, comparable to others. Some fit different sizes differently. So it's just checking that the patient is comfortable with the one they've got. The other thing you can do as well is you can combine your wraps. So we will double and triple layer hosiery, which might sound a bit scary, but we might have a class 3 with a class 2 on top and a wrap on top of that. So what you can do is you can take the foot piece and you could put that on top of a stocking for foot swelling, or you can take just the knee piece and the thigh piece. If the knee's starting to swell from an existing garment, you could put a knee piece and a thigh piece on top in order to encourage that fluid up. So if someone's not trained in full leg bandaging, you could use a thigh wrap on top of that as well.
Right, there's something else occurs to me. You know, being probably the oldest person here, I remember perhaps in the 70s and the 80s when you had these slender tone machines and similar, where you had electrode pads that you attached to various parts of the body, and they were supposed to make you thin overnight. Well, they work pretty much along the line of these circulation booster machines. So they use the current to contract muscles. And I'm wondering actually whether the effect of those, if indeed they did work, I have to say I didn't try one myself. But if they did work, I wonder if they were actually acting on the lymphatics and not on the muscles.
Yeah, maybe, but you did see the muscle contract with those, and there are similar magnetic electrotherapies available, and they do contract the calf muscle. So you might put a probe each side of the knee and it will contract the calf, which contracting the calf will have an effect on the venous system and force the fluid up, making the veins more effective. So there are treatments like that available. They do use them for wound healing as well. And so I think that, anything that will get the calf muscles pumping and working better is going to make a difference for lower limb lymphoedemas.
So the basic message is get them moving. Get
moving. Yeah, absolutely.
Little message from Brenda there. I'm sort of glad Martin also gets overwhelmed. Believe me, I overwhelm very easy at my age. So we're in good company there, Brenda. Now, from Hayley, you mentioned earlier on in the presentation, compression potentially restricting lymphatics. When can compression be harmful?
Maybe hosiery.
Hosiery, yes, hosiery be harmful rather than helpful.
Well, it can be harmful, of course, in patients that have got arterial problems, ischemic limbs and arterial. In your diabetic patients is all your contraindications. Your cardiac patients, where you're forcing fluid up, that can be causing increased fluid and renal and kidney problems. So I think those are your contraindications where it's harmful. In lymphatics, when we're looking at those as causing obstruction, it's really in the upper limb that we see it most of the time, because gravity is higher in the lower limb, that compression garments is usually warranted. But in the upper limb, when we've got that dermal rerouting, what happens is that the lymphatics almost go on an overpass, and they go on the skin, bypass, and then go down into the deeper into the deeper vessels that are functioning. Whereas, and once they've created this dermal rerouting, what happens is if you put a sleeve on, then the fluid that's trying to come from the bottom has to reach high pressure, like blocking off a hose pipe, in order to force underneath the compression garment to drain out. So we see it on arms. I've not seen it on legs so much, but probably because when we get to see legs, they're usually at a more severe stage of a lymphedema developing. So.
Right. Jill sent me a private message saying that Hayley has her hand up to ask a question. Are you happy for me to unmute her? So,
yeah, absolutely.
So yeah, fine.
Thank you.
Hello. Hi.
Hi, thank you for that. The thing that I'm finding most frustrating with patients that I encounter with lymphedema is their hopelessness, particularly obviously in those that have more severe cases. Is there any kind of hope for them? Because they seem to feel quite abandoned by the system, certainly in terms of the NHS. Is there anything that I can sort of say to them to give them some hope that there is improvement to be had, and can I point them in any particular direction as to where they can get that help that they need?
Yeah, thank you. I think it is really difficult, Hayley, because it's easy me standing here saying this, you should do this, this and this, and that's fine, me sitting here. But when you've got a patient who is depressed, they're increasing weight, they're not motivated particularly well, it is a bit of a catch-22. And I think what I found is that when you've got patients who are stuck in that, is that doing treatment and nagging them and saying, look, Mr. Smith, you need to lose weight and you need to wear these every day and you need to whatever is not always the most helpful. You have to do it together and figure out what it is that's stopping them. So what are the things that stop the progression to something new? Sometimes that's that they can never see themselves going out, or they don't have any friends to socialize with. So what's the goal of them improving and getting better? That they've always been told that they're no good, so they don't believe that they're ever going to have be healthy again. So I think there is a catch-22 of that. And so I think that it is working psychologically with the patient and psychosocially. And unfortunately, we don't always have the time to put that into patients. But if you can just do one thing and get them on, you know, even if we're looking at diet and it's boredom beaters, so when is it that you turn to food, or is it stress that does that, or is it that it's usual every time you sit down and have a cup of coffee that you have a biscuit? Can we change any of that and try and improve that situation? The daft things that, you know, when you're going to the kettle, putting the kettle on up and down on your toes, or when the adverts come on, or can you start exercising, or can you take a ball? I actually had one earlier, I don't know where it's gone. Can you take a ball or rolled up pair of socks and place it into your kneecap and just start bending your knee and emptying those lymph nodes? And I think also showing that if you can just get a little bit active, the other things will start to come. So as you start to become more active, lose a little bit of weight, the switch takes place then. Psychologically, you start to then become much more positive, and you can work with that. We do another training as well called Turnabout. And our Turnabout training, it's running on the 6th of September actually, is about that negative voice in your head. And the negative voice in your head that tells you that you're rubbish, you're no good, my mom said this, she said that, and the things that lay down our kind of values and beliefs that are our self-fulfilling prophecy of who we are. And so we do training on looking at intercepting that, finding out what that is, how it affects our life, our love life, our finances, our health, and everything else as well. And it's as effective and necessary for clients and patients as it is for ourselves.
Great, thank you very much.
Thank you. That is excellent. Quick question for Mia here. I have a client that can't find shoes or socks. Is there a special place to make shoes and socks for the problem, please? Even compression socks, as given by the NHS, don't fit her. So are companies.
So there are, we can, I mean, as podiatrists, there are the usual places to go. I want to say Cozy Feet and Reed, I think it is the other one, and there's cast shoes that you can get on that your patients can have, so they can just be in a walking cast shoe. But of course, as you'll know, when you're putting the patient into a flat shoe and you haven't got any you know, on your gait, and you're not got your venous pump, then you start to walk flat-footed, and then you start to get edema. One of the things that we did a survey on with a moisture meter, that little probe that you saw, is we looked at plantar edema. I think we're the first in the world really that's measured plantar edema, and we could see that on 60%, or I think it was 45% of people that had swelling of the feet, that had plantar edema into the foot, into the arch of the foot. And so we think that having an orthotic in there may stop edema collecting on the arch of the foot and may alter gait a little bit, so that you're not banging internally or medially when you're walking. So yes, there's a lot to do with footwear and getting people into the footwear so that they can flex as they're walking. And there's a few links, I think, that, but they're non-prescription again, unless you go for a cast shoe, that anybody would be able to get on those, because they're all Velcro, but they don't help you with walking. And what else does she say? Even compression socks as given by the NHS don't fit her. Maybe she's not being measured properly as well. Compression, I think there are so many different companies that do compression now, all the classic companies. So you've got Juzo and Hadnam and Sigvaris and Medi and LNR and so on, and they go on, and they have so many different types of material and compression and tightness and classes that it really is a fine art trying to decide on what's the most appropriate. And sometimes people will go to the garment manufacturer that has been to see them the most, or the one that they have that they're most familiar with, but they all fit slightly differently, and they have different tweaks on, some being a different shape at the ankle, some having a different top band on them. So I would say that if she hasn't got the right compression garment, there's probably one out there that will be right. It's just finding the right manufacturer is the problem.
Thank you. There's another question here from Leanne, and that's what about patients that are on a lot of medication? Can manual lymphatic drainage be contraindicated? So polypharmac patients, what about them?
No, not really. MLD isn't contraindicated to many things. In fact, I'd say it's not contraindicated to anything. We'd just say proceed with caution if someone has a cellulitis with MLD. Proceed with caution if you've got somebody who has a severe cardiac problem, and other than that you tend to be okay. But some medications do, like calcium channel blockers, do cause the lymphatics to slow down, so that's how they work. So instead of the pulsation that you get normally in the lymphatics, that slows, slugs, and then you get edema sitting in the tissues. But as far as manual lymphatic drainage goes, there's not really anything that is going to cause a problem unless your patient's having chemo into that arm or something like that. But of course, it's on an individual basis. So I'll put my hand up and say I'd need to know individual things on that.
What just went through my mind there was with things like malignant melanoma, for example, as you know, we'll often do sentinel lymph node biopsies for that. So with something like that, would we take them off the manual lymph drainage if they were, for example, in stages of being treated for a malignant melanoma? Yeah,
so what we would usually do is if we suspect a recurrence, we will stop treatment. However, generally, if your patient's walking and breathing, they're circulating any mutant cells. So it's not particularly contraindicated, but for good practice, we will stop at the point of suspecting a recurrence and then continue once they've been seen by oncologists. As far as the treatment goes before, so we wouldn't do any MLD if the patient was going off to have surgery or anything like that. We'd wait for them to have their surgery, chemo potentially, and then we'd start to see them throughout without any worries. It's always a big debate about massage and cancer, and there's no evidence really to suggest that you do spread cancer because the patient's active and moving anyway. And we always ask and say you should check with your doctor or the consultant first. And it's that balance, particularly in palliative patients, of keeping comfort. Sometimes it's for head and neck cancer patients that we can keep them to be able to see and to visualize and be able to see their loved ones regardless of the cancer. So it's always a balancing act with our palliative and cancer patients.
That's excellent. Now, I think we've got another couple of messages. I'm conscious of the fact that we're running well over, but let's have a look. Would compression hose be recommended for people still in early stages?
Yes, for the very early stages of lymphedema. For a lower limb, I think yes, absolutely. But for arms, we're now suggesting that if we can do fluoroscopy and we can see where the problem is, they literally just have to help the lymphatic system by massaging it a bit. And that would be enough. And we'd monitor them, I would suggest, for the next 4 to 6 weeks. If it's got worse, you need compression. If it hasn't, that might be enough to maintain that situation for them. But for lower limb, because of gravity, because it's in the feet, then compression, is compression's king.
Right. Okay. I think we're going to have to leave it there because, as I say, we're a good quarter of an hour over it. I hope we're going to talk again at length.
Yes, that would be great. Yes.
The other thing is, can I do a plug for Podiatry Review, which is our quarterly professional journal? It's peer reviewed. And it has a circulation, I think, about 2,500, something like that, in the world of podiatry and people interested in it. We're always looking for interesting articles for that.
Okay.
So if there's a frustrated writer within you, and you fancy putting something together, I think we'd be delighted to feature that, because
No, that'd be great. I am a frustrated writer. I've got so many things I need to write up. The things that we're doing with fluoroscopy, the drainage routes, it's all absolutely brand new, and it's just time in order to write and publish. So yeah, it'd be good to get you something, and yeah, we'll do that for you.
Oh.
We, the royal we, of course.
Of course, and we've now got that recorded. You know, we've got it recorded now.
Okay.
I think what we've got to do now is I've got to give you a huge thanks on behalf of the audience, and also on behalf of the Institute as well. You know, you've shared this with us tonight, and I will certainly look forward to talking to you again in the future. And I'll also
It's been a pleasure.
articles as well. And you know, I do think that these courses that you're talking about, they're really relevant to podiatry and foot health, and it's something I would urge people to consider taking. I mean, even at my advanced age, I think I should consider taking one as well, because at least I needn't look so nonplussed when a patient turns up with a huge leg and says, "What can I do?" And I say, "Don't know, I'll refer you to somebody else."
Yeah.
As we do.
Yeah.
Well, thank you very much indeed, Jane, and thank you also to the people who attended tonight.
Yes, thank you everybody for attending and listening.
Right, so thank you. Back to you, Jill.
Brilliant. Thank you very much, everybody, and we'll see you on the next one.
Okay.
Yes, I think that's the pain sequence we're starting next time, isn't it?
It is, yes.
Right, okay. Well, I'm afraid you'll have to put up with me for the first one of those. So we'll talk about pain. No pleasure, just pain.
Brilliant.
Okay. All right. Well, thank you, everybody, and I'll say good night to all of you.
Okay. Thank you. Thank you, everybody.
Thank you.
Mhm.